Palindromic rheumatism, PR, is a rare type of recurrent arthritis characterized by sudden, recurrent episodes of joint inflammation that last for a few days and then resolve completely, leaving no lasting joint damage. Unlike chronic forms of arthritis, such as rheumatoid arthritis, RA, PR episodes are intermittent, and patients often experience periods of normalcy between attacks. However, PR can sometimes evolve into RA or other chronic rheumatic diseases. Key features: 1. Acute attacks. PR typically involves sudden onset of pain, swelling, and stiffness in one or several joints. The affected joints can vary from episode to episode. 2. Duration. The episodes usually last from a few hours to several days, after which the symptoms completely subside, often without leaving any signs of joint damage. 3. Asymptomatic periods. Between attacks, patients are often asymptomatic and joint function remains normal. 4. Migratory pattern. PR may affect different joints at different times, and the pattern of joint involvement can change from one episode to the next. 5. No permanent damage. Unlike RA, PR does not typically lead to permanent joint damage, although a subset of patients may eventually develop chronic arthritis. Diagnosis. Diagnosis of PR is clinical, based on the pattern of symptoms and exclusion of other types of arthritis. Laboratory tests may show elevated inflammatory markers, e.g., ESR, CRP, during attacks, but these usually return to normal between episodes. Rheumatoid factor, RF, and anti-CCP antibodies might be positive in some patients, particularly those who later develop RA. Differential diagnosis. Palindromic rheumatism should be differentiated from other episodic joint conditions, such as gout and pseudogout. Rheumatoid arthritis, chronic form. Systemic lupus erythematosus, reactive arthritis. Treatments. Nonsteroidal anti-inflammatory drugs, NSAIDs, are often used to control symptoms during attacks. Colchicine. Some patients benefit from colchicine, which may reduce the frequency of attacks. DMARDs, disease-modifying anti-rheumatic drugs, e.g. hydroxychloroquine, can be considered for patients with frequent or severe attacks or those at risk of progressing to RA. Prognosis. The long-term outlook varies. While some patients experience only occasional, mild episodes, others may have frequent, disabling attacks. Around 1/3 of patients with PR eventually develop chronic RA, and careful monitoring is necessary to detect early signs of this transition. If you're looking for a more in-depth review or wish to include specific elements, such as recent studies or guidelines, please let me know. Epidemiology of palindromic rheumatism. Palindromic rheumatism, PR, is a rare rheumatic disease, and its prevalence varies across different populations. It is estimated to affect approximately 1 to 2 per 100,000 people globally. Age of onset. PR most commonly begins in middle-aged adults, typically between 30 and 50 years of age, but it can occur at any age. Gender. Similar to rheumatoid arthritis, PR shows a slight female predominance, with women being affected approximately twice as often as men. Familial occurrence. There have been reports of familial clustering, suggesting a genetic predisposition in some cases. Regional distribution. PR appears to occur globally, but studies suggest varying prevalence in different regions. For instance, a relatively higher prevalence of PR has been reported in Southern Europe and parts of Asia, particularly in populations with a genetic predisposition to autoimmune diseases. Studies in Spain and Israel have noted a higher frequency of PR among patients with RA-related autoantibodies. Some reports indicate that ethnic and geographic factors may influence the clinical course, with some populations having a higher likelihood of progression to RA. Differential diagnosis. The episodic nature of PR, with spontaneous remission between attacks, makes it a diagnostic challenge. Several other conditions must be considered in the differential diagnosis. 1. Gout. Similarities. Gout presents with episodic acute arthritis, often affecting a single joint, especially the first metatarsophalangeal joint. Differences. Gout attacks are typically longer, days to weeks, and can lead to chronic joint damage if untreated. Elevated serum uric acid and monosodium urate crystals in joint fluid help confirm the diagnosis. 2. Pseudogout. Calcium pyrophosphate deposition disease, CPPD. Similarities. Like PR, pseudogout can cause sudden joint inflammation and pain. It often affects the knee, wrist, and other large joints. Differences. CPPD is often associated with chondrocalcinosis, visible on x-rays, and calcium pyrophosphate crystals in the synovial fluid. 3. Rheumatoid arthritis. Similarities. PR may be an early manifestation of RA, and about one-third of patients with PR eventually develop RA. The presence of RF and anti-CCP antibodies in PR patients can be a sign of impending RA. Differences. RA typically leads to persistent symmetrical joint inflammation and can result in joint deformity over time, which is not seen in PR unless it progresses. 4. Systemic lupus erythematosus. Similarities. SLE can present with episodic joint pain, particularly in early stages, and affects multiple joints. Differences. SLE is a systemic disease with multiple organ involvement, skin, kidneys, CNS, etc., and positive antinuclear antibodies, ANA, or anti-dsDNA are often present. 5. Reactive arthritis, RA. Similarities. RA can cause episodic arthritis, often after a preceding infection, e.g. gastrointestinal or genitourinary. Differences. RA is associated with a history of infection and may present with extraarticular symptoms like conjunctivitis, urethritis, and mucocutaneous lesions. 6. Psoriatic arthritis. Similarities. Psoriatic arthritis can cause intermittent joint pain and swelling, similar to PR. Differences. Psoriatic arthritis is often associated with a history of psoriasis and may involve dactylitis, sausage digits, and nail changes. 7. Familial Mediterranean fever, FMF. Similarities. FMF is a hereditary autoinflammatory disease that can present with episodic arthritis, especially in people of Mediterranean descent. Differences. FMF typically involves fever, serositis, e.g. peritonitis, pleuritis, and elevated inflammatory markers during attacks. Genetic testing for MEFV gene mutations can confirm the diagnosis. 8. Other autoinflammatory syndromes. PR may also need to be differentiated from other periodic fever syndromes and autoinflammatory conditions, such as cryopyrin-associated periodic syndromes, CAPS, or TNF receptor-associated periodic syndrome, TRAPS, which also present with episodic inflammation. Additional diagnostic tools. In addition to clinical assessment, the following diagnostic tools may aid in differentiating PR from other conditions. Joint aspiration. To rule out crystal arthritis, gout, or pseudogout by examining synovial fluid for urate or calcium pyrophosphate crystals. Imaging. X-rays, ultrasound, or MRI can help assess joint structure and inflammation. While PR generally does not cause permanent joint damage, imaging can help exclude other arthritic conditions. Serology. Testing for rheumatoid factor, RF, anticyclic citrullonated peptide, anti-CCP antibodies, antinuclear antibodies, ANA, and other autoantibodies may assist in identifying underlying autoimmune diseases, such as RA or SLE. If you'd like further details or specific references, feel free to ask. The classification criteria for palindromic rheumatism PR are not as well established as those for conditions like rheumatoid arthritis, RA, or systemic lupus erythematosus, SLE. However, over the years, rheumatologists have developed working criteria based on clinical observations and patterns of symptoms to help identify PR in practice. Classification criteria for palindromic rheumatism. 1. Recurrent episodes of acute arthritis. Sudden onset. Pain, swelling, and stiffness in one or more joints that develop suddenly. Short duration. Episodes typically last a few hours to a few days, generally no longer than 3 days. Spontaneous resolution. Complete resolution of symptoms without any long-term joint damage. Intermittent nature. Asymptomatic periods between attacks where the patient feels entirely normal. 2. Variable joint involvement. Episodes can affect different joints at different times. Migratory pattern. Both small, e.g. hands, wrists, and large joints, e.g. knees, shoulders, may be involved. Symmetrical involvement is less common than in RA. 3. Absence of persistent arthritis. No persistent joint swelling or deformity between attacks, which helps differentiate PR from chronic inflammatory arthritides such as RA. 4. No evidence of permanent joint damage on imaging. X-rays or other imaging modalities show no erosions or other signs of chronic joint damage, which are typically seen in RA. 5. Exclusion of other episodic joint diseases. Other causes of recurrent joint pain, such as gout, pseudogout, reactive arthritis, and familial Mediterranean fever, should be ruled out through clinical history, laboratory testing, and imaging. 6. Response to NSAIDs or colchicine. Many patients experience symptom relief with nonsteroidal anti-inflammatory drugs, NSAIDs, or colchicine, which may also help reduce the frequency of attacks. Additional supportive criteria, not mandatory for diagnosis. 1. Positive rheumatoid factor, RF, and/or anti-CCP antibodies. Up to 50% of patients with PR may test positive for RF or anticyclic citrullonated peptide, anti-CCP antibodies, which are typically associated with RA. While not required for diagnosis, their presence can suggest an increased risk of progression to RA. 2. Elevated inflammatory markers during attacks. Blood tests may show elevated erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, during attacks, but these markers usually normalize between episodes. 3. Subcutaneous nodules. Some patients develop transient subcutaneous nodules during attacks, similar to the rheumatoid nodules seen in RA, though they disappear after the episode resolves. Limitations. Lack of standardized criteria. Unlike other autoimmune diseases, PR lacks universally accepted classification criteria, making the diagnosis somewhat subjective. Rheumatologists rely heavily on clinical judgment and exclusion of other conditions. Evolution to RA. Approximately one-third of patients with PR eventually develop RA. Therefore, early identification and monitoring are crucial for detecting potential progression. Proposed EULAR criteria, 2023 update. In recent efforts, the European League Against Rheumatism, EULAR, has suggested more formal criteria, though these are not yet universally adopted. Recurrent attacks of joint inflammation, lasting from a few hours to 3 days. At least 3 documented episodes within a 6-month period. Complete resolution between episodes. No chronic arthritis. Laboratory criteria may include absence of tophi or crystals on joint aspiration to exclude gout or pseudogout. Presence of autoantibodies, RF or anti-CCP, though not required. The EULAR criteria emphasize the need for longitudinal assessment to differentiate PR from evolving RA. Would you like to explore these criteria in greater detail or have further clarification on the EULAR recommendations? The European League Against Rheumatism, EULAR, periodically provides guidelines and recommendations for the diagnosis and management of various rheumatic diseases, including palindromic rheumatism, PR. However, PR-specific recommendations are often discussed in the context of broader guidelines for inflammatory arthritis, such as those for rheumatoid arthritis, RA. While EULAR hasn't provided an exclusive guideline dedicated solely to PR, the following key points reflect the most relevant guidance from EULAR related to PR, focusing on diagnosis, treatment, and management strategies. Diagnosis and classification. 1. Early identification. EULAR emphasizes the importance of recognizing early signs of inflammatory arthritis, including conditions like PR, which can be a precursor to RA. Regular monitoring. PR patients should be monitored for any progression towards chronic forms of arthritis, particularly RA. The presence of anti-CCP antibodies or rheumatoid factor, RF, may indicate a higher risk for such progression. 2. Exclusion of other causes. EULAR recommends a thorough differential diagnosis to exclude other episodic joint diseases, such as gout, pseudogout, reactive arthritis, and autoimmune conditions like systemic lupus erythematosus, SLE. Treatment recommendations. 1. Symptom control during attacks. NSAIDs. EULAR guidelines recommend the use of nonsteroidal anti-inflammatory drugs, NSAIDs, as first-line treatment for controlling acute symptoms of joint inflammation during PR attacks. Colchicine. Colchicine is suggested for patients who experience frequent attacks as it can reduce the frequency and severity of episodes. 2. Preventive therapy. Hydroxychloroquine. EULAR supports the use of hydroxychloroquine, an antimalarial drug with anti-inflammatory properties for patients with frequent PR attacks or those at risk of progressing to RA. This is based on evidence that hydroxychloroquine can reduce the frequency of PR episodes and may also help prevent progression to chronic RA. DMARDs. Disease-modifying anti-rheumatic drugs, DMARDs, such as methotrexate, may be considered in patients with persistent symptoms or those with a high risk of developing RA. While these medications are not standard for all PR patients, they may be beneficial in cases where PR shows signs of evolving into chronic inflammatory arthritis. 3. Patient education and monitoring. Patient education. EULAR emphasizes educating patients about the episodic nature of PR and the potential for progression to RA. Patients should be informed about the importance of regular follow-ups and reporting any changes in their symptoms. Monitoring progression. Regular monitoring, including clinical evaluations and laboratory tests, e.g., RF, anti-CCP, inflammatory markers, is recommended to detect any signs of progression to RA or other autoimmune diseases. 4. Tailored treatment approach. EULAR guidelines advocate for a personalized treatment approach based on the frequency and severity of attacks, as well as the patient's risk factors for disease progression. Treatment should be adjusted according to the patient's clinical course, with close collaboration between the rheumatologist and the patient. Follow-up and long-term management. 1. Long-term follow-up. EULAR advises long-term follow-up for PR patients, given the risk of evolving into RA. This includes regular clinical assessments and laboratory monitoring, especially in patients with positive autoantibodies or other risk factors for chronic inflammatory disease. 2. Early referral to rheumatology. EULAR encourages the early referral of patients with suspected PR to a rheumatologist for proper diagnosis, management, and monitoring of disease progression. This is particularly important in cases where PR may be a precursor to RA. Conclusion. While there are no PR-specific EULAR guidelines, the recommendations emphasize early recognition, symptomatic management, and monitoring for progression. The overarching goal is to prevent chronic joint damage and to tailor treatment to individual patient needs.